Thank you very much. Introductions like that always makes life very difficult because I'm going to do nothing but disappoint from here on in. I'm told I can sit. I hope it's okay. And if you can't hear me, you can shout. And as your nice Barnes and Noble cafe had only large coffees, please shout if I speak too quickly because I wasn't able to get the small size that I'd hoped for. So I was asked today to talk about sort of some of the economic work that we've been doing and trying to bring some of the issues which we've had in that to the discussion. So really it's to raise some of those issues. And in doing that, although I think I'm going to just try and sneak in a couple of other pieces of the work we're doing more as examples, but also just because it might be a little bit interesting to you. But before getting into the body of the presentation, I always remember my supervisor during Masters, which now is feeling longer and longer time ago. But my supervisor during Masters would be very annoyed with me because she said that I wrote like a stripper. In that I would always show people a little bit and then cover it up, and show people a little bit more and then cover it up, and then surprise and expect them to have figured everything out by the end. And so that it's much better idea is to be a little bit more upfront about where you're going. So we'll just go really to what are some of the sort of core themes of what I'm talking about, and then we can get into the more flash show version. So resources are scarce, and it's unlikely that we're going to get very many more for HIV, and so we have to be careful about how we allocate what we have. So, we went through a period with rapidly increasing resources, and, this allowed us to experiment in many different ways, to try different areas of work. But those days are clearly gone, and we're having tightening of belts and, potentially shrinking of resources. And so obviously the importance to think about how we allocate resources is obvious to everyone, and hence the theme that you've been hearing is that cost being mentioned more and more frequently. So economic evaluations can help, and I undertake economic evaluations. I believe in them. I think there's a lot of use that can be gained from all types of economic evaluations. But we should be careful when doing these evaluations that priority setting not be reduced to a technical exercise. There's no means of economic evaluation which will clearly tell you what to do in all circumstances. And I think this, I'm glad we have a visiting economist here along with me who can hopefully testify to the same thing. It's a frustration both for economists and for practitioners or people in other areas. People in those other areas say, they plan everything and then sort of hand it over to the economist to look at the priority setting, and then complain bitterly when they don't like the results of that process. And so you often end up with a tension where the economists are saying, well, we've applied a technique, and the others saying, well, we just simply don't agree with what has come out. And so what I wanted to highlight as much as possible is that often those disputes result from a disagreement in values, in that the economic evaluations are great provided you agree with the values on which they are based. And that when you don't agree with them, it's typically that difference in values, and it's not necessary then to focus in on having a discussion about the technique. One wants to get down to a discussion about the values. Because, even as an economist, I would suggest that you do not leave your value discussions in society to economists. You may not like the conclusions we come to. But you can't ignore it. So if you ignore priority setting, then you leave priority setting to chance. And we've seen, particularly when resources were more plentiful, but even more so now that we see, national AIDS plans, everything is in there. Absolutely everything that anybody wants to put in there. And as someone who works primarily in the children's field, this is a particular concern. No one in the children's field ever wants to prioritize anything. If you ever have a meeting on children affected by HIV, the end list of recommendations is everything. And if you try and leave anything else to say, but what about the child who's like this? What about a child like this? And of course, those are all important things, and you end up adding and adding, and you end up with a laundry list of recommendations. But then we don't have the resources to implement those. And so somebody ends up choosing. Now, sometimes that's an economist who might go through a priority setting process. More likely than not, it's implementers who choose which part of the plan they want to implement. And that could be for a host of different reasons. What is easiest, what they were doing last year, what would benefit their cousin who runs a company that does this type of thing. There are all sorts of potential ways in which priorities can be set if priority setting isn't done as a systematic process. So it's really to emphasize that there are value-based decisions and that they need to be taken very seriously, and the process of priority setting needs to be taken very seriously. Or really, we have to ask ourselves in the research field, what is it that we're doing? So, we come out in HIV with all these recommendations, we publish them, and then that we hope somebody will take them up because they're a good idea. Are we engaging enough in what the process through which things become priorities, what it involves and how one can engage in that and how one can provide the necessary information to support that process. So to start with, we just wanted to recap on the investment framework, which they've varied a little bit since they first published it, but I find with UNAIDS, typically the first time they say something is probably the most honest, and then they doctor it, determined by the political response that occurs thereafter. So the first formulation of the investment framework was basically making the argument that if you could invest more resources in the coming years, we could do enough to respond to HIV that we could really get it under control, and that if we didn't, we would be paying for a very long time, which was a nice sentiment, but it occurred almost simultaneously with the fact that we could see that we really were not going to get the resources to expand. And then the investment framework became much more about saying, how do we spend those resources that we have in the most efficient manner to maximize the impact? Now, what I wanted you to think about in this is, I mean, they've produced several diagrams, and the diagrams do keep changing. This is actually not from the Lancet, but from a second publication of theirs, but it essentially summarizes the same thing, is that it characterizes the HIV response in terms of two objectives: stopping new infections and keeping people alive, which are obviously at the heart of responding to HIV. But is that the sole, are those the only objectives of the response to HIV? Is there no mitigation? Are we not trying to prevent the effects of HIV that will occur even when we've done as much as we can for stopping new infections and keeping people alive? When we're keeping people alive, are we looking to keep them alive in the best possible state of health, the best possible state of well-being? Is there something more that is missed by characterizing the epidemic only in terms of these two outcomes? And that changes depending on what the objectives of your response are. That will change what is prioritized. So if you're prioritizing solely in terms of these two, which I don't think anyone is suggesting, but just to be clear, if you are prioritizing solely in terms of these two outcomes, then you're going to have a very narrow response. And you are left with the difficult discussion about how do you balance stopping new infections with keeping people alive. That is not going to be a technical exercise. There's a technical exercise there to tell you how most efficiently you can stop new infections. And there's a technical exercise that can tell you how most efficiently you can keep people alive, but not how to balance the two. To do that balancing requires a value judgment at some point, even when you use measures like disability-adjusted life years and such. I'll come back to it in a second. But what that then means is also the synergies with development sectors and the critical enablers while there. And so when we talk, from the children's sector, we say, well, you've forgotten children. They say, well, we have, the synergies with development sectors. Well, what that's saying is, in this formulation, is that the synergies with development sectors are important only to the point that they support the outcomes that you're interested in. So you want the development synergies in order to stop new infections or keep people alive. So you've narrowed your goals quite extensively. As I say, as the investment framework has evolved, obviously they talk about other goals and other things that you wish to consider. But this formulation highlights very clearly what happens when you focus in on narrow goals. So having this sort of blinker approach it can be good and bad. So I don't want to pretend that it's an all bad thing to have these things. So when you focus very particularly on a limited set of outcomes, such as, deaths and infections, this can help promote efficiency. You don't have everyone running around doing everything. You say, let's be clear, what is it that we're trying to do, and let's get it done as best as we can. And so, this is critically important in the response to HIV as resources become tighter, that we stop as many new infections as we can and we keep as many people alive. No one would dispute that. So that drive for efficiency is good. But it doesn't tell you just on those measures alone, what about equity? Do we mind who stays alive? Do we have any view on that at all? Do we have particular biases which are creeping in because of that? When we focus only on HIV outcomes, and I'll return to this, we'll end up biasing vertical programs that speak directly to those HIV outcomes and not necessarily interventions that have broader outcomes. So, for example, strengthening the health system will have outcomes in terms of keeping people alive who are HIV positive. It will have those benefits, but it'll also have a host of other benefits for people broader than HIV. And if you're focused solely and using some sort of cost effectiveness analysis on keeping people alive with HIV, those benefits are excluded. You don't consider them. They're not in the informational frame, and therefore you won't put as great a value on interventions which have multiple benefits. And so the programs which are much narrower, the vertical programs, tend to be biased. And that's even more the case now. If you come to poverty reduction, and something we come across very often is that when you talk about poverty reduction, if you have these very narrow goals, which are becoming increasingly popular, not just in HIV, but there's increasingly popular across development sectors, that we want to have efficiency, it's never worth it to respond to poverty. It's not worth it to respond to poverty just to improve primary school enrollment. Actually, that might be one that it is. But generally, it's not worth responding to poverty for HIV prevention, for HIV treatment. It's not worth responding to poverty to deal with maternal mortality or to deal with quality of educational outcomes and so forth. Because each individually, it's not worth it. It's only worth it when you look across sectors that it becomes worth it. And so if we continually prioritize within our own sector, we miss those broader frames. And there are ways in which you can bring that in, and we'll come back to that. But what I wanted to talk about a little bit more, because the outcome stuff is fairly straightforward in many ways and something which is a familiar problem. And the problem I think that we have in HIV is that we also tend to narrow in on the population that we're dealing with. So you've already heard that, I'd work on children affected by HIV, so I spent a lot of time lobbying almost for what it is that one should do for children affected by HIV. Then you get the treatment people who lobby for treatment and the prevention. You're looking for not subpopulations even. So then you have the PMTCT people. You have all these population focus, and you're asking what is the best thing to do for this population, not necessarily what is the best thing to do more generally. And sometimes it's not the best thing. Those two don't overlap. And so maybe to be also a bit, to highlight how much of this is sort of value-based is to ask the questions, should PMTCT option B plus be prioritized? So it's something people tend to feel quite strongly about. So for those of you who are not familiar, prevention of mother-to-child transmission originally, so most recently had two options, option A and option B, which involved different drug regimens. Option B in particular involved putting people on an ART regimen during pregnancy and during breastfeeding, and then, unless they required it for their own health, stopping that at the end of 2 years. So option B plus just says you put everyone on treatment and you keep all mothers on treatment for life. And the rationale for that is that it will lead to better health outcomes for the mothers over the long term, and that it will lead to reduced infections because more people will be on treatment, and so treatment will act as in a preventative frame. So is that the right idea? So just, think to yourselves for a second whether or not you think that's the right idea. So, if we look for, if we just do a simple sort of cost-benefit analysis type of approach and ask, do the benefits outweigh the costs for option B plus? So obviously there's costs. It's more drugs. So you have to provide drugs for a longer period of time for more people, so there's costs. But then there's the women's health benefits. There's some debate you might have about the extent to which women's health will benefit from this, but let's say that those outweigh the costs. Then you say there's women's health benefits and transmissions avoided. So you've already had to broaden the information frame to make a stronger case. You're not just focusing on one set of outcomes, but you're saying that there are broader benefits for society as a result of more people being on treatment. Now you can begin to think, if you wanted to treat people in order to prevent future infections, would pregnant women be your first choice? So new mothers, are new mothers the highest risk group? Is that the vector of transmission that we're looking at? I'm not sure that that's the case. I'm just unclear how many other infections you would avoid, but let's just say that you avoid some of those, and then you see that it's beginning to look like a more favorable option. But then we have to start asking questions about what we do and do not know. So no evidence of harm is not evidence of no harm. So you're putting people on treatment very early in life. We don't think that there's any harm to that from taking the drugs for that long period of time. We think that the benefits for health will outweigh that, but we don't actually know. We don't have any evidence to support whether or not that's going to lead to some harm. Maybe there's some, but there's certainly not definitive evidence of that. So if that harm is not too much, then you will still have it weighing in favor of providing that service. But if that harm is far greater, if, for example, we have problems with adherence during that people, and people who stop adhering are then less likely to take drugs in the future when their health does deteriorate, or those drugs are less likely to be effective, then we will see much larger costs associated with having option B plus. But all of that is still very much all relevant questions, all issues that, taking an evaluative approach, sort of economics evaluation approach, starts to speak to how one needs to consider all of these outcomes, and broader than women's health, looking at the population, what transmissions can be avoided. But if we even put the potential for harm aside, then comes down the question, should mothers be prioritized? Because that's essentially what we're saying with option B+, is that if you have a CD4 count that doesn't qualify for treatment under current national guidelines, if you are pregnant, you will get treatment for life. If you are not pregnant, or if you are a man, you will not get treatment for life. And so is it an appropriate thing to prioritize mothers ahead of other women? So you can start to think of some arguments. This is where I snuck in some other research. So where you start to think of arguments of why you might want to say you prioritize mothers. So here we looked at a cohort of women in the South African context to see, well, a cohort of 100,000 women born in 1985 in South Africa. What does their life look like in a high treatment, high prevalence context? So you see, around the 20s, infections go up, and then I've got a pointer, this more orange line, and people go on to treatment. South Africa's quite high rates of treatment, and that goes up. So you have a sense of what's going on with women in general. And if we take that and think about both age and how HIV affects your fertility, we can begin to try and understand what is the link from women's HIV to children. So we can see this is now children's age and the status of their mother at that particular age, given the pattern of the epidemic in South Africa. And you can see then obviously you have very large increases, even with high rates of treatment. You have quite high levels. Under normal circumstances, you would have about 10% of mothers would die by the time a child reaches the age of 18, and that's increased there to, where is that, around 70 or below 70. And then a substantial number on treatment, and a substantial number asymptomatic or as yet still asymptomatic by 18. So there's clearly potential for impacts here on children, because mothers are HIV positive, they are unwell. We have lots of evidence of how this links, and we can begin to look at that. So we look at, for example, what effect that might have on school enrollment. So, we find that if there were no HIV in this cohort, you would have school completion of around 61%, which highlights in itself that, South Africa, even as a wealthy country, would still be having a problem with school completion. But that the population level, which is then quite significant to be able to say we have a population level impact of HIV on children, would drop to around 57% school completion, and amongst those who are affected by HIV in any way, so their mother is positive, asymptomatic, sick, dead at any point in their life, the school completion is 50%. So there's clearly potential for an impact on children. So should we then be prioritizing mothers? Because you have these benefits both for reducing transmission more broadly, and you have these benefits for children. So do mothers then get should mothers then be prioritized for treatment? So is a test and treat for mothers an appropriate thing? But that leaves out a whole host of other issues, and this is what I really wanted to draw out, was the extent to which priority setting is not a simple task. So it brings out a whole set of other issues. So now we've gone full circle with PMTCT. We used to say that it was a problem to provide drugs only to protect the child from infection. What about the woman's health? You can't just make the woman an instrumental in this. You have to take care of the woman's health. So we talked about treatment for the woman. Now we're saying women can only get treatment for life early, provided they have recently given birth to a child. If they have an older child, that doesn't matter. So you have to be in care of a recently born child, and then you get treatment for life. So that women are now back to being instrumental. You have to qualify. So presumably it's for an argument for the benefits to the child. Men, they don't get treatment. Other women, already we've established, don't get treatment, even if they have the same CD4 count. Men, even those more in urgent need of care, and we know that treatment uptake amongst men is much lower than treatment uptake amongst women. But yet we're wanting to expand treatment access to women, which when you are thinking about mothers, seems like the right thing to do. Where I talk about the population blinkers, you are now asking, so this recommendation comes from people working in PMTCT who are concerned with the women in front of them. And for their mind, the women in front of them would be best benefited by putting them on treatment for life from the moment that they are tested positive. So for them, it's the right decision. No one's questioning their intention. But the priority setting, once you're now looking at a broader picture and you no longer blink into a particular population, you start to ask these questions about other women, about men who are actually much more likely to die. And in South Africa, we always talk about the heavy weight of infection on women, which is true, and I wouldn't want to detract too much from that. But the lifetime risk of dying from AIDS in South Africa is not that different for men. You don't ever see the same level of prevalence, but that's a lot to do with the fact that men don't access treatment, so they die a lot quicker. And so if you combine higher access to treatment for women and the very low access for treatment for men, the lifetime risk of HIV, while still higher for women, is not as much higher as we like to pretend. And so, are we moving then? Once you start asking about other populations, you have to ask, why is this a priority option B+? Is it a step towards test and treat? Is that where we want to go? And so therefore, this is just purely a step. Well, if it is a step, then we should be openly discussing it as a step and saying, this is logistically easy to do. Here's a population we can reach. But our goal is to eventually reach everybody else. So this leads you to these sort of questions about what it is when you when you go outside of the population. And you can see already that all of these issues are taking us to debates which are not purely technical. Is it right to provide more to mothers because they will have benefits to the children? And then how can you justify that on a moral basis by excluding other women who could be in a worse state of health but who don't have children? How can you justify that when considering about men? And this now takes us broadly to see that we have been very focused in lobbying for our silos, and this is the type of intervention that we get when we focus very closed on a particular group. And this leads us to broader discussions about, well, how much should we be spending on prevention as opposed to treatment? So is there some rule of rescue? We have to respond to the people who are currently HIV positive, currently ill. We have a special duty to respond to them. So that's a reason why we want to still focus on treatment. But how much so? How far should that go? That's a moral discussion. And discounting. We like in economics often to discount lives. So we say, well, we must protect this life at the moment, and lives in the future are of less value. Now that comes from a theory about money generally, is that you prefer consumption today to consumption in the future. A life today and a life in the future is always a different life. It can't be the same life because you can't save it in the future if you didn't save it today. So these are now trading different people. Now, aside from uncertainty of saving a life in the future as opposed to saving a life today, is there any reason why a life in the future is worth less than a life today? Is there some basis for that? That's a moral discussion. We put discounting in the economic models as a rather routine exercise. And while that works very well for financial benefits because you could invest that money and it could achieve that return over the time, it doesn't work so well for people. So you can also control for age. You can say, is saving the life of a 10-year-old today of equal or less or greater value than saving the life of a 10-year-old in 5 years' time? I mean, what is the difference, aside from the uncertainty associated with the two? So with that backdrop, I wanted to bring to very simple discussion around economic evaluation, with the hope that you realize already that it's going to obviously be much more complicated than a technical exercise. Cost effectiveness analysis, which is the most common method which you use, which is not economics, accounting, but fine. It's a simple approach, and it has got some very useful applications. When you have a specific budget or a specific goal, your value judgment's already been made. So if you say we want to spend 10 million on prevention of mother-to-child transmission, you have already made a value judgment. It's embodied in the fact that you think it should be 10 million and not 20 million. Cost effectiveness analysis will now speak to you about how you can spend that money on different interventions and which set of interventions would more efficiently produce the outcome that you want. But the value judgment's already made. It is then largely, not exclusively, but largely a technical exercise. But now when the budgets become less and less specific, the value judgment is less and less specific. So now you don't have 10 million allocated to PMTCT, you have 10 million allocated to health. How do you spend it? Now, you've already made a decision. There's a value judgment there that it's a health benefit that you are seeking, but how do you balance across different interventions which are balancing across different people? And that's where measures like the disability-adjusted life year or quality-adjusted life year come in order to allow you to use cost-effectiveness analysis across these. And that's fine, provided you agree with all the values that are embodied in a disability-adjusted life year. So just think for a second. I mean, we often use these measures very mechanically. If we think for a second that disability-adjusted life years have made a decision about what is the relative value of living with a disability or living with poor health and being dead. So they put death and ill health on the same scale. And some people would say you can't do that. Others would say that you can. I mean, but the point is it's a debate. And so if you disagree with the results, it may be that you disagree with either the relative weight of ill health and death, or that you disagree entirely with putting them on the same metric, that you can't. Some people feel very strongly that you can't put them on the same metric. Of course, at some point, you have to make a judgment about how much to spend on preventing death and how much to spend on improving health, but that is maybe a debate which is better had in a sort of more public forum and more explicitly discussing where it is that the society's values sit, rather than having it embodied in a technical measure which one uses for cost-effectiveness analysis. Similarly, again, discounting. The same point is that in order to do these things, we often have to make decisions about whether we discount lives, we discount poor health. The same thing. What is poor health this year as opposed to poor health in 10 years? And if that's the same person, that's maybe one thing, but if those are different people, should we be discounting the future life? I mean, I have my own view on what the answers to these questions are, but at this point, that's not important. The point is that the exercise of evaluating requires you to have taken a view on the values that are embodied here if you wish to use cost-effectiveness analysis. Otherwise, you tend to end up with inappropriately the prioritizing of vertical interventions, pretending that we can use it in a way in which we actually can't. And that tends to, as I say, lead to these very narrow interventions. Cost-benefit analysis can include a lot more and can be extremely helpful. And it is economics now. It's not, it's not accounting anymore, which is, of course, a step in the right direction. So it's a potentially much more useful technique. But it's particularly useful when it lends itself, when the costs and benefits lend themselves to be measured in monetary terms. But when they don't lend themselves to monetary terms and you have to find techniques of putting values on people's lives or people's health, then it becomes more controversial. Again, perfectly acceptable provided you agree with the values that are used to determine the value of people's lives. So, someone might say that you want to look at productivity as a means of valuing people's lives. Other people may find that highly offensive. So if you agree with that approach, then you should agree with the results. If you don't agree with their approach, then you should maybe question the results. Now, something which I think we do often in the child sector and we do often in HIV is we get quite excited sometimes when you can show with fairly uncontroversial financial benefits that something pays for itself. So, you do prevention, you save on future treatment costs, people can work more, they earn more, and there's all sorts of clear financial benefits which flow from that investment, and the investment will in fact pay for itself. And so we go off and we trumpet this, and that's no problem. We should trumpet that. But we have to then be very careful that are we setting ourselves up for the time when they don't pay for themselves? Because we are confusing that we're not doing it simply because it pays for itself in financial terms. If we were doing it simply because it paid for itself in financial terms, we'd invest in the stock market. We're doing it because it has another benefit, another level of social benefit, because it improves somebody's health, it saves lives. And great, it has all of these other financial benefits which will pay for itself. So while making the argument that it pays for itself is a very strong argument, and one which I don't object to at all, we have to always clarify that that's an added argument, that we would be saying this even if it didn't pay for itself. So, we don't want to set ourselves up that we find huge financial returns for protecting the health of working age men, and then suddenly we find that pensioners not so much, and then we're left scrambling to make a more balanced argument for the pensioners. So in thinking about this, we developed an approach, if you like. It's not particularly a radical departure, but an approach to thinking about economic evaluation, which we called the cost of inaction. And as I like to say, it successfully solved all the problems that I discussed with you, every single one of them, and then introduced a whole load more, which in fact may be worse. So it's a case of, choosing which set of problems it is that you want. And I think many people will still choose the problems that come with cost effectiveness and cost benefit analysis. We personally would choose the problems that we introduced by doing this and having solved some of the problems of cost benefit and cost analysis. But it is a trade-off. We don't pretend to have come up with a nice, neat solution. So essentially what we were suggesting was that people should conduct a cost-benefit analysis. That's the better of the two approaches, but without the obsession with putting everything into financial terms. So there's no need to necessarily put this into everything into money units. But that, as I said, there's advantages of that and some very large disadvantages. So to just summarize the approach a little bit. So the cost of inaction, where first of all is very clear, is not the cost of doing nothing, but the cost of not doing a particular thing. That you can't say, often we talk about what is the cost of inaction. We talk about all of these excess deaths. We talk about the burden of disease. We talk about these very large impacts that we see. But many of these negative outcomes that we see, there's nothing you could do about them. So they are not a cost of inaction. Or there's nothing that you could do about them within a reasonable use of resources. So they are bad things. They are terrible things that happen in the world, but they're not costs of inaction. What portion of them, we ask, are a result of not undertaking actions that you could undertake, which requires you then to define an action and evaluate that. But what we find is that starting from this point of inaction draws your attention much more towards sets of interventions than it does to individual interventions. So often when we do cost effectiveness or cost benefit analysis, we talk about one intervention at a time, as if the environment in which that was applied is static. But often things worked much better together. So, in the education sector, for example, we look at the returns to early childhood development. But now the returns to early childhood development interventions, preschool, essentially, are not that great if your child then doesn't go to school. So, it's designed, partially at least, to improve school performance. And if there's no school to go to, as in, we were doing this in Angola, there were often no primary schools to go to, then what do? You say that the benefits to that are not large, or do you say, well, what is the benefit of having a package which includes early child development and primary school? So I encourage you to say, well, the environment is not fixed, there's inaction in various aspects. Can we consider what is the package of interventions that one applies? Now, both of those, starting, having a particular action and drawing attention to a set of actions, you can do in a normal cost-benefit analysis, not as easily in a cost-effectiveness analysis, but you can do them anyway. Where we take a bit of a departure is that we say we prefer to have a vector of benefits evaluated. So we want to know everything that happens as a result, everything as far as possible, so it is more data intensive. As far as possible, everything that results from this particular set of actions. So what are the financial benefits? What are the savings to life? What are the outcomes for children? Can we draw a fuller picture as possible of the intervention that we're talking about to be able to feed that into a process? Now, you can already start to see where the problems come in. So firstly, this means we can't rank interventions. And that's the strength of a cost-benefit analysis and a cost-effectiveness analysis. It tells you this is number 1, this is number 2, this is number 3, this is number 4. We're saying you can't do that, but we're saying you also shouldn't do that. That to do that requires a value judgment to have been made, and we're not the ones who should be making that. That's a process that should be making that. But that requires that process to exist and be understood and be able to inform. So that's a big ask. And often we find that while we think we're being very empowering to the policymakers actually say, oh, please, we don't want to enter into these difficult discussions. If you could just tell us what to do, we'd be very happy about that. And so there is a big trade-off. There's often quite a want for a very clear answer, and this isn't a clear answer. So that's a big con on that side. And also, when you list all these benefits, you can risk getting a bit confused. You can risk saying the points that I was raising earlier, that mothers now become instrumental, that they're, protecting the health of mothers is important because of the benefits for children. So we try and draw a distinction between constitutive and consequential benefits. So we talk about constitutive benefits being the reason you do the intervention, some status which is accorded to that set of benefits because that set of benefits is the real reason why you did something. So you protect women's health because it's important to protect women's health. End of story. That is a constitutive benefit. There are then all sorts of consequences of protecting women's health or undertaking an intervention to protect women's health that are also relevant but are of a different order. So they are consequential benefits. So we like to separate out the two. The relative weight you place on constitutive or consequential is then part of the value judgment which people are asked to make. But all of those benefits are essentially individual benefits. They're private benefits. We're talking about benefits to people, and we have to avoid welfarism. We have to avoid saying that society doesn't also value values, that they are not, principles which we wish to uphold. So maybe while we see supporting mothers has large consequential benefits, maybe we have a problem in discriminating against women based on whether or not they've recently had a child. And so we wish to use the consequential benefits for women as argument for consequential benefits from mothers as an argument for more spending on women in general, but that we don't want to distinguish where that spending goes because we value some equity in terms of access to services among women, possibly among men too. So you have to consider all of these values. But already you can see we're making this process a whole lot more complicated than it was before. And what we're highlighting, hopefully, is that actually if we want to meaningfully set priorities, one has to do that. And so it's important to bring all these issues in, because that in the real world is where the things that people are thinking about when setting priorities. And there's no reason why one cannot have a nested cost effectiveness analysis and a nested cost benefit analysis within that. To say, here's an intervention. It's quite efficient, not that efficient. But we think you should think about it. Firstly, look, there's all of these financial benefits which flow from that, and there are all these other benefits which flow from that. So it's not saying that you don't do the other two. It's just saying we need to be thinking from the beginning of a larger informational base if we want to meaningfully contribute to the priority setting process. So that then brings us very much to what is this priority setting process that we speak so highly of. And typically it's this random thing of people choosing their cousin's business. And so it gets quite difficult to think about how one is feeding into that. You don't want a consequential benefit, potential for bribery. That's not something we want to have to highlight. But it does then push us to say, whose values are supposed to be reflected in these priorities. So much of the money spent in HIV is international money, but does that mean that, it's about 50% now, so 50% from domestic sources. But so whose priorities should be reflected in that? Does where the money come from mean that people should have a say in how it's spent? There's a good argument that there's, to at least some degree, there should be some influence. But there's a good question to say the extent to which local governments and affected populations need to be involved in the way in which that priority setting is done. And are we investing enough in actually supporting the process that this priority setting can occur? And that we're not just saying, you need to do priority setting, we're going to go away and conduct a technical exercise and come back and tell you what to do, that we need a process. The technical exercise of identifying efficient interventions, of identifying cost-beneficial interventions, and of presenting all the other benefits does need to be done. It doesn't take away from that, but then it needs to be done to what end? To feed into a process that can be used to set priorities. And I think critically is, are we making enough effort to understand the way in which priorities are actually set? So, I'm guilty of this as much as most other people are, is that, you do your work, you find out a good solution and you publish it and then you're done. But how much is that likely to affect policy? What will it take to affect policy? What are the issues which are salient for policymakers in thinking that through? Are we being strategic in understanding that process? Not to trick them, not to say, this is flagging exactly the right thing that they want to hear, but to try and inform them and to try and have a meaningful debate and discussion about the priorities which are being set in order that we can more meaningfully contribute to the discussion of what should be done so that it isn't left to random. So all of this, as I say, to go right back to the beginning, is to say, highlight that there are very many technical issues in economic evaluation which are critically important if we want to think about how best to use our resources. There are, however, a whole load of other value judgments which really need the input of a much broader range of people, and I think it's critically important that we bring those to the fore and that we try and provide an environment in which we can discuss and understand them, and so that we can have priorities that are truly reflective of the values of those people that they should be reflecting. Thank you.